Dr. Folkerth, Dr. Folkerth is currently a principal core scientist at the Neuropathology Brain Bank, responsible for evaluating traumatic brain injury cases from the long-term effects of TBI study at the Brain Injury Research Center, Icahn School of Medicine at Mount Sinai in New York City. From 2016 to 2023, she served as the neuropathologist for the New York City Office of Chief Medical Examiner and as clinical professor of forensic medicine at the New York University Grossman School of Medicine. Prior to joining the New York City OCME, Dr. Folkerth was affiliated for nearly 3 decades with the Harvard Teaching Hospitals, Brigham and Women's Hospital, and Boston Children's Hospital. She was director of the neuropathology services at Brigham, while serving as an integral consultant in neuropathology at BCH and head of their joint neuropathology training program for many years. Dr. Folkerth's research interests include abnormalities of the developing brain, having participated in several long-running NIH-funded projects at BCH on perinatal hypoxia ischemia, as well as sudden infant death syndrome with her mentor, Professor Hannah Kinney, with whom she still collaborates. The latter study brought her to South Africa numerous times and sparked her interest in teaching in other international settings. She also has been involved for over a decade in NIH-funded traumatic brain injury research with an international group of scientists, including a subset who developed consensus criteria for chronic traumatic encephalopathy, or CTE, pathology. Current work focuses on brain injury associated with intimate partner domestic violence. She is fortunate to have been a co-author with dear friends and colleagues, Professor Mark Del Biggio and Professor Mirna Lechpalmer, of their textbook, Perinatal Neuropathology, which was published in 2021. And I am really looking forward to today's talk. So please go ahead.
All right. Hi, everyone. It's nice to not see you here, should I say? But to know that you're here, and I'm really thrilled for your interest here. I'm going to start right in because we got a lot to cover. All right, so here we go. This is what we're going to go over today. I'm going to go over some of the etiologies that lead to brain swelling, but as you well know, almost any neuropathologic process can lead to brain swelling, but I'm going to cover the main ones. We're going to go over the definitions of swelling and edema, the cellular bases, the radiographic appearances of them, because in some ways the different types are distinguished more on imaging than we're able to do in pathology. And then I'll give you case examples of different types of herniation, showing the tissue displacement into various compartments, and then the host of secondary changes, which are almost more important because they can be confounding when you're faced with a case, particularly one that's maybe lived for a few days and has a lot of superimposed changes. And then also the alterations that are induced by our dear neurosurgical friends and colleagues. And then finally, in a couple examples of those who survive these interventions, what things can look like over a little bit of time. I'm going to touch on brain death. That's such a huge topic, but it is relevant to this because that seems to be the final common pathway in a lot of these cases. All right, so here are the primary etiologies we're going to go over today. We always think of trauma as being one of the leading ones, which it is. And that can be either from a localized impact, contusions, which can, if very severe, develop into hematomas, subdural hematomas too, for example, extraparenchymal. And then the torsional diffuse axonal injury. Again, I'm not talking about that today, but just so you know, it can and does lead to brain swelling. Then our various non-traumatic mass lesions, which can be localized, or sometimes in the case of infections or even neoplasia, can involve the leptomeninges and the ventricles and can secondarily lead to hydrocephalus, which has its own set of changes, which we'll touch on. Hypoxia ischemia, a very common one, generalized, related to cardiorespiratory failure, such as an opioid overdose, which is primarily respiratory failure. And then various metabolic derangements will lead to brain swelling, and we'll just touch on that as well. And then we can have local hypoxic ischemic lesions, ischemic strokes, and then hypertensive hemorrhage per se are not a primary hypoxic ischemic injury, but they often result in perihematoma ischemic changes, which can result in herniation. Then there's dural venous sinus thrombosis, as well as cortical vein thrombosis, which is an interesting entity, and I'll show you an example of that in a PD case. And then infectious meningoencephalitis can result in brain swelling, again, from multiple different pathways, and we'll just touch on that again. I'm not really going to get into examples of non-traumatic subarachnoid hemorrhage, for example, from ruptured saccular aneurysms, inflammatory demyelinating lesions like acute MS, epilepsy, especially status epilepticus, can result in significant brain swelling. And then, high altitude injury, toxins, heavy metals. I'll show you one example of that here, but I think we'll get a grip on this from these other examples, and then you can kind of generalize to other situations. Excuse me. So brain swelling is the term I prefer, but what it equates to is an increase to the volume over baseline. Volume of what? Well, the volume of normal brain tissue, right? The intravascular blood volume within the brain, and then the CSF within a fixed cranial volume. And this is the key thing, which adults have a fixed cranial volume. Babies, a little different. We'll talk about that as we go along. Now, this volume actually has a bit of a range, and it's dynamic, right? So it's not always the exact same, volume. That's because there are differences in cellular metabolism, gray versus white matter. Blood pressure fluctuation will result in a constantly changing overall brain tissue volume. And CSF actually has a pulsatile quality that results in periodic waves of increased volume and pressure over time. And that's all in the normal brain, right? So when there's an increase, that's when we, over this baseline, slightly fluctuating level, this is when we get a problem. And this can be because the brain tissue volume increases, either the number of cells, usually the interstitial fluid, and this is what actually is edema, right? These other things are not. You can have an increase in intravascular blood volume, malignant hypertension, and so on. That is not really brain edema per se. It's swelling, but it's resulting not from increased fluid, but from increased blood volume. And then CSF, if you have a acute increase in the volume, it's hydrocephalus, so it's really not edema, right? So, and then the pressure is the summation of all of this stuff, right? So this is why I like the term brain swelling. It's what I use in my reports, because it's acknowledging that, first of all, I can't be certain about which specific cellular basis it is. And frankly, at autopsy, it doesn't really matter. And often you may start with one main cause, but you'll end up with a gamish of a lot of different things going on. And so it's a little bit presumptuous to think that, pathologically we can discern these things, because histology is almost always not really helpful, and not, in a practical sense, you don't take sections to determine the cause of the brain swelling, right? Unless it's a tumor and you need to know exactly what type it is, that's a little different. So I just want to make this point here. I think people use cerebral edema really loosely when it's probably not the most accurate term. So that's just my little editorializing there. Now, this photo, which I apologize, is kind of wonky looking because I was getting it from the LISMA, the actual textbook. So it reproduced in a weird way. So sorry about that. But I kind of like it, even though it looks like Edvard Munch's The Scream guy, But here we've got the spinal cord, the cerebellum, and the brain as a tissue volume in a confined space. We've got the CSF volume, which freely moves around, but is secreted at a constant rate. And we have The blood volume, they're not really depicting it here, but we know that it's there. And so the total volume is going to be the volume of the brain and cord tissue. And we're going to stop thinking about the cord here so much in a minute. The intravascular blood volume, the CSF, and then you've got this lesion, whatever it is. Let's say it's a subdural X. That's contributing a certain amount of volume. And so when the volume of this increases beyond the ability of CSF to move, to be reabsorbed and kind of make a little more room, then you've got increased intracranial pressure and you've got a problem, right? And so that when this enlarges or expands, more CSF gets driven out until there's no way it can go out. And the brain will shift away from this mass effect, which itself can induce, and it's not showing very well here, but a little localized ischemia, pressure ischemia right next to the mass. So then you get, a shift of the falx, and you can get compression of the ventricle unilateral to the mass. And because sometimes that means the outflow of the other ventricles is compressed by tissue, you can get expansion and trapping of these lateral ventricles, which is also a problem because choroid plexus churning away, making CSF, no matter what's going on, it's still doing that, right? So what happens then is the herniation, and it's not always brainstem herniation, but anything can herniate, but that's going to be the kiss of death there, okay? So on from these kind of semi icky drawings. They're not great, sorry, but I like them better than some other ones I found. Okay, so the different bases of brain swelling are cytotoxic, vasogenic, osmotic, and interstitial. So cytotoxic means the cells themselves have disruption of their cell membrane homeostasis, and the cells swell up. This happens in TBI and in stroke. Whereas vasogenic is where the blood-brain barrier is disrupted and plasma components will enter the perivascular space and the interstitium and that's actual edema, right? This is edema. And this happens around tumors, abscesses, hemorrhages, whatever you want. And then we have osmotic, which means that the blood osmolality has gone up, and then there's a fluid shift, or rather the osmolality goes down. So the blood is trying to equilibrate and fluid goes into the interstitium, right? And so this happens with rapid correction of whatever is increasing blood osmolality. And then we have interstitial, which is the pressurized movement of CSF into the interstitium in the setting of hydrocephalus. Again, these are important to understand in terms of making the diagnosis pathologically. We aren't always called on to do this. The importance of this is in radiology because certain different types will respond to, mannitol and steroids and things like that, and some don't. So that's the reason clinically sometimes there's an effort to distinguish among these things. Now here's our intact blood vessel with the proteins in it and the fluid. This is the normal state. The brain cells are sitting here quietly, floating around in their interstitium. And this movement is tightly controlled of water and proteins. Now, if something damages these cells, if they don't get enough oxygen and their membranes get messed up, their sodium potassium ATPase pump gets messed up, they're going to take on water. But the actual, and the cells will increase in size. So it's cytotoxic edema, but it doesn't actually result in an increase in brain volume, right? You haven't added anything net to the system. But with increased blood-brain barrier permeability, you get opening of these pores, and you get fluid going into the interstitial space and protein, and this will result in an increase in the volume of the extracellular space. Okay, so I want to make sure everyone understands that concept. And osmotic is a little bit similar to this because you've got too much fluid here And so it'll come into the brain here. I mean, too much fluid relative to the particles in the blood. Okay, so radiographically, cytotoxic edema, the classic is an ischemic infarct, right? And that's because at this point, at the very beginning of the infarct, the blood vessels are more or less structurally intact, but the ion transport is messed up, right? Astrocytes get involved, and that's part of the reason there's poor distinction between gray and white matter. So the radiologists contend. And then here's an example of a toxic condition. So if you're exposed to trimethyltin, that's a toxin which will result in white matter edema greater than gray matter edema. This is very rare to see, and it's intramyelinic edema, so it actually is affecting the oligodendrocytes. And then vasogenic edema, this is the kind we're most used to seeing, around localized lesions such as tumors, and here they've nicely outlined it in purple in case we couldn't quite tell that it was visible here. And this is from physical disruption. By arterial hypertension, direct transmission of pressure to the capillary bed, and this is transudation into the extracellular space. It tends to involve the white matter more than gray matter, again, according to the radiologist, but those of us who've looked at plenty of autopsy brains know that this cortex is also swollen, right? So a tumor or an abscess, these have vasoactive factor expression, as we well know, and so on. And then intracerebral hemorrhages also result in a similar change around them because that results in disruption of the blood-brain barrier. Same with the trauma with a bleed. Posterior reversible encephalopathy is basically a vasculopathy, and so it results in similar changes. And these are just some other examples of that. This is, so once blood flow starts to be reestablished through the ischemic brain tissue, the blood vessels have now become hypoxic and leaky, and that's when you develop secondary vasogenic edema on top of a cytotoxic edema, and this is reperfusion hemorrhage, as you see here, okay? So that's why these are kind of a mixed bag once you get to that point. Here's a nice tuberculoma. We don't see that very often, but they sure do in places like Africa, where I've taught before over the years. Similar deal. And then here's an example of posterior reversible encephalopathy syndrome. These posterior vessels have a slightly different sympathetic innervation than the anterior vessels, and they are more prone to vasogenic changes actually related to their innervation and why they tend to become leaky before the anterior circulation. So that's, again, these are just radiographic examples. Here's osmotic edema. Basically, everything gets a little too much water in it. And so when the plasma is diluted, then the water will enter the interstitium, right? It's just the law of equilibrium. And this is usually very diffuse, and the gray and white are still distinguishable because they're equally affected, okay? DKA, things like that, SIADH, that's when you're going to see that kind of thing. And then with obstructive hydrocephalus, this is when you see the ventricular expansion and this periventricular, transudation of transependymal flow of CSF. And it's most notable where the CSF is under pressure and moving into the tissue, and the protein will be low here. It's essentially a CSF transudate. And so this is a non-contrast CT scan, and this is an axial flare, which really shows it quite nicely. So as I say, to make these distinctions, the radiologists have got a better grip on it than we have. Yeah, because microscopically, it's kind of hard to tell the difference among these different types. Often you'll see pallor of the myelin. You might see little vacuoles here, a sieve-like appearance. But again, this is involving the gray matter, so I would beg to differ a little bit that maybe the white matter is easier for the radiologist to see, but I think it does involve both. The subpeel spaces can be rarefied. This is not really being shown here. And sometimes you'll see pools of protein-rich fluid around the blood vessels, and I'll show you a better example of that from my own cases in just a second. So again, we don't really rely on the microscopy so much. Now, here's a case that we published. This was an infant with who died of COVID back in the horror days. And we did a post-mortem ex vivo neuroimaging scan, and were able to detect some of these really widened perivascular spaces with signal abnormalities. And this is what they kind of corresponded to, where you could see this bubbly stuff around the blood vessel and some widening of the perivascular spaces. Again, we were a little speculative about this, but it certainly seems like that could be what that is showing. And again, you wouldn't necessarily call that on the basis of the histology. It's just the best example that I could show you of my own stuff. Now, here's another set of examples from our studies into partner violence, again, in which we did ex vivo imaging and detected these sort of very funny vascular type patterns corresponding to pallor of the white matter, expansion of the perivascular spaces here. And when we looked at really high power in the white matter, we could see this proteinaceous rich fluid in the perivascular space. And in fact, that was fibrinogen. So the little diagram I showed you with the particles going into the brain, that's one of the particles here are the fibrinogen leaking through the vessel. So you can detect it. And again, for certain types of queries you may have, that's how you can do it. Here's an example of the triethyl tin toxicity, where if you have EM, that's great. So few of us do anymore. But this is where the detection was made of the intramyelinic edema. You see how it's pulling apart the lamellae of the myelin. So that's a very specific type of change, but it's fluid that's in there, so it is edema, right? Okay, now let's move on to some examples and patterns of herniation. So here we've got I love these drawings. This is from this antique book that I actually borrowed from the AANP archives. Just so you know, these things are available to all of us. And this is showing, so here's the frontal lobe. Here would be the splenium of the corpus callosum, and showing this nice impression of the falx with herniation of the cingulate gyrus. And here's one that's transtentorial. This is a mid-sagittal view showing a similar impression of the tentorium against the hippocampal gyrus. And then this is a basal view, and we're all quite familiar with this. I'll show you some real tissue examples, and then obviously the transforaminal herniation. Now, just a note here about terminology, and I have a foolish consistency as a hobgoblin of a small mind, as Emerson used to say, but I like to either use what sort of compartment is being traversed, subfalcine, transtentorial, transforaminal, or what tissue is being herniated. In my report, I try to choose one or the other. They're both correct, of course, but I think it's good to just be consistent in that way if you can. And then we have one that's, I think, underappreciated. I've noticed it a lot in our trauma cases. It tends to be, so here we are at the base of the brain, optic chiasm. So if you've got a big frontal lobe mass, like a big orbital frontal hematoma or something like that, sometimes you'll see the posterior orbital frontal tissue get pushed into the middle fossa, and you'll get this impression from the lesser wing of the sphenoid. So just a thing to be aware of. I tend not to specifically call it out in reports, because when you have that, you usually have a bunch of other stuff too. Then if something's going on in the cerebellum, it will sometimes push up through the tentorial notch and be supratentorial. So just to be aware of those, I'm not really going to show you examples of those today. Never to forget the external, I love this, fungus cerebri, which I'll show you some good examples of. And then you can have, in the cases that are more the osmotic ones, where the entire brain is swollen, you'll get centroencephalic herniation here, which is everything sort of swells up at the same time. It doesn't have anywhere to go but down, okay? And here's an example of a centroencephalic herniation. This was published by Jim Powers and his group a million years ago. But it's really nice because it shows a 9-year-old with DKA who was treated and rapidly, decreased the amount of sugar in his blood. And here's what he came in with initially with the swelling. And after 2 days, you can see this is the part of the brain that is herniated down. This is centroencephalic herniation. And after 24 days, this is essentially all necrotic. And then this is these are very unusual examples. I don't even have one of my own to show you. So just so you be aware, but this pattern is quite interesting. It's a centroencephalic. And again, once you lose the space here around the midbrain, the cistern here, quadrigeminal cistern, ambient basal cisterns, then all hell breaks loose. Okay. So I'm going to show you some real world examples of these, acute and subacute, chronic, et cetera, without further ado. All right, so these are 5 cases that have similar, the story can be the same for all of them. 50-year-old ejected from a car in an MVA. Here's an individual with a right parietal fracture. It's very hard to see, I found, but it is here, and it's coming through where the middle meningeal artery comes through, and here it is with the dura still invested in the calvarium with this very circumscribed, like a lemon here, right? And when the dura is peeled away, you have this hematoma here. And of course, it can result in shift and herniation and everything else. I'm not going to show you that in this particular case because it's going to look similar to some of the next ones. And then here we've got the right parietal fracture, blah, 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 which I didn't show you. And here is what it would look like radiographically. And I really like this image, which I stole off the internet, where you've got like this lemon, whereas a subdural is more like a banana. So, and I'll show you this in just a second. So here, same story, 50-year-old tossed out of the car in an accident, left subdural hematoma, more of a banana shape than a localized lemon. Here's the calvarium removed and flipped over. So you've got the left subdural. Now here's a bridging vein. It's very hard to tell if they're actually torn or not. I've had that come up in court where they're like, well, did you demonstrate the vein that was torn? I'm like, no. But that's where they are. And when they're pulled, and they're very thin-walled, as you all know from having done autopsies, that's the origin of this bleeding, no matter what other people might tell you. Here's another case, acute right subdural at autopsy, and you can see how it really spreads to cover the entire surface. And when that clot, which acutely can be really friable and can actually wash off, so that by the time you get the specimen, if it's fixed, you may not have much blood left, but you can see how this has been deformed acutely by that mass effect. And again, it's more broad-based than the epidural. And so that when one looks at the brain after fixation, you see this sort of areas where it's been compressed and pushed over to the side, subfalcine herniation, big transtentorial herniation here. And in fact, some of this almost looks like it'd be necrotic. And you've got a dura hemorrhage here. You've also got entrapment of this left ventricle because this pressure has compressed the foramen of Monroe, right? So meanwhile, choroid plexus churning away, and this is expanding. It contributes actually to the overall intracranial pressure and the downward herniation and death, okay? So again, for that one, subdural hematoma, midline, both of those last two, entrapped ventricle and secondary brainstem hemorrhages. So again, our banana type analogy here. So after a few days of survival, a little more of the clot is going to stick to the dura, so it gets a little easier to confirm what was seen at autopsy if you weren't there. And what you might also see then are some secondary changes. So here we've had this big left subdural. It's still shifted here. The midline should be something like this, right? And you've got all of this tissue shifted over. Here's a huge uncinate hernia. In fact, it's squished the PCA on this side. So you've got a big PCA infarct on the left in the entire territory. And on coronal section, this is what it looks like. So you've had this much deformation. And again, we call out the subfalcine or cingulate gyrus hernia here and the uncinate, but look at the whole, it's almost like the entire deep it's herniated into the ventricle on that side and cause compression. So we don't speak of it that way, but that's basically what's happening. And again, you can see here's an infarct with some reperfusion hemorrhage. And it's a little hard to tell here, but there was, in fact, a Durée. So that's one after a couple of days. And let me just go back one second, because what you can also see here, look at the cingulate gyrus that's herniated under here. It's got little petechial hemorrhages, and that's sometimes called a herniation contusion. And that's a terrible term because it's not really a contusion. It's because this tissue has become ischemic and had some reperfusion hemorrhage in it. So that's the more accurate terminology. So you would say compression, ischemia, and reperfusion hemorrhage, but in colloquial, conversation, it comes up all the time, herniation contusions. And again, the entrapped ventricle and the secondary compression ischemia and Durée hemorrhage. So those are all the secondary things going on here, just to be aware. Okay, here's a case that's cut in axial section, which my trainees from the OCME know I love to do these, especially in complex cases where you've got a lot of trauma and interventions and one thing and another. And if some of you are curious how to do this and haven't really messed around with it, I'm glad to talk with you offline about it. It's actually a very straightforward thing to do. But here it ends up, you instead of it being right on the right, left on the left, like we do in coronal sections, we do it more CT type. So this is actually the right hemisphere. So we had a left SDH with compression and shift. Again, here's our cingulate hernia. Here's our uncinate hernia. And this also had contusions with contusion hematomas as well, right? Looks like there's been some blood in the ventricle here. Again, this ventricle is entrapped. And let's see what else. And this is what it looks like at the base. So it's a little funky looking, but if the left subdural is here, we have these contusion hematomas, and here's the hernia here, but we also have compression of the other uncinate against the tentorium, which is called the Kernahan's notch phenomenon. And obviously the midbrain is toast at this point. So the Kernahan's notch phenomenon is when you have compression of the peduncle and the uncinate process contralateral to where the mass is, okay? Straightforward. And so this is how one would write this one up. So you see, I'm showing you these so you kind of get a flavor of how one would report these and the similarities among them. Again, you want to differentiate the primary traumatic injury from all the secondary stuff. That's in forensics, that's the holy grail. Okay, let's show an example of a chronic because we're getting toward the end here. And I've still got a lot to show you. This is a guy who was punched while he was in the hospital for a foot infection, had a brain bleed, had to go to a nursing home with all kinds of other stuff going on. So he did not do well, right? He had to have burr holes for decompression. He had to have, obviously these are the burr holes. This is a beautiful subdural neomembranes, bilateral, right greater than left. You can see the little neovasculature here. It's wonderful. You don't need to take a section of that. I mean, unless you're interested and want to, but you can make the diagnosis without it. That's an old subdural, and after that, they kind of look like that all the time. Now, it turns out this guy had lacunes in his left pons. They said he had CVA, and so you can see the volume is a little bit decreased here. In fact, he's got atrophy of the contralateral descending tract on that side related to this. So his things would be summed up for him. He had blunt impact injury, but he also had cerebrovascular stuff with his secondary degenerative changes. Now, whether this was considered natural or a homicide, I can't remember how it got resolved in the end, maybe undetermined. Okay, here are 50-year-old bicyclists struck by a truck at an intersection. And here's a left subdural acutely, a right subdural acutely, where, we see our beautiful hernias here, and we've got our Durée hemorrhages, right? So we've all seen those. I hope we've all seen those. So in terms of the cause of those, these are some wonderful old injected arteries showing here's the basilar, the paramedian, and the short and long circumferentials. And so, and this is the end arterial distribution of these. Okay, so this is where the blood vessels are compromised and will bleed. Okay, and this was a normal brainstem that was injected with silver iodide while the lateral brainstem was being compressed and sort of generated these post-mortem Durée type hemorrhages, which you can see here, which have led to, this idea that when you have shift of the brain, it tears these distal vessels and you get the Durée hemorrhages in the midbrain and pons. You do not see them in the medulla. If you have hemorrhages in the medulla, they are not a Durée hemorrhage. The other thing that is underappreciated, I think, is that often these hemorrhages will go up into the diencephalon, and you will see that. And here is a cross section or a mid-sagittal section of such a case with midbrain hemorrhages, and in fact, they even start to go up into the diencephalon. This is an example from Dr. DeGirolami at Brigham and Women's, showing how you'll sometimes see these. This is not the type of hemorrhagic tissue tear that you see in a torsional injury. This is a Durée hemorrhage that's gone all the way up into the diencephalon. So keep an eye out for that. You will see it. People can survive rarely from these, and this is what they look like. Again, rusty, old Durée hemorrhages. Okay. Now, here's a couple pediatric cases, acute and subacute. This again, I've given you the generic stories. 2-month-old brought to the ER unresponsive without an adequate explanation, i.e. suspicious circumstances. Okay. And of course, when you open the head, you can see sites of blunt impact injury to the scalp. Here's a left parietal skull fracture. And the other thing that you'll notice is that the sutures are widely spaced apart here. This is sutural diastasis. And when you remove the calvarium, you can see where the sutures were because there's this little trace of blood here. Sometimes there'll even be extramedullary hematopoiesis in these, and that is an indication that the sutures were widely pulled apart. Now, you also have got a little trace of epidural hemorrhage that underlies this fracture. And notice the swelling where you've got a artifactual rent in the dura, the brain is herniating out, right? So this is a typical story. So little babies, you will not see a typical herniation pattern. This is more what you will see because that's where the brain goes first. It goes out rather than down. And if the survival is not very long, you won't see any evidence of herniation. Again, here's a fluid bilateral subdural, very swollen brain, but it doesn't really look that it's very interesting. I don't exactly know why, but I think it's because the sutures accommodate until they can't anymore, and then that's it. And there's, it's tight here, but it's not exactly herniated. So I think that's an important thing to realize about pediatric cases. So they can have the impact injury and swelling and so on but you may not see any herniation there at all. Here's one that survived for 3 days. Again, the hematoma is a little more stuck on the dura here. There were also ocular hemorrhages, which we're not going to talk about today for lack of time. But this is what happens with the diffuse brain swelling in a baby. You get brain death, essentially. And then everything is, this is very unfortunately what we see a lot because, of course, they resuscitate these babes until there's nothing left to be done. This particular case also had some hemorrhages in the cervical nerve roots and presumably suffered shaking because there wasn't an impact site on the head. But notice also that there's some ischemic change in the cervical cord. This is because there was a couple days survival, and the brain will become ischemic and brain dead before the spinal cord will. You also have here cerebellar emboli, which if we go back for a second, oh, I don't have the cerebellum here, but you can imagine cerebellum looked just like this. So the tissue was dropping down into the spinal canal. And I'm sorry, I don't have a photomicrograph of that to show you. So this is, a inflicted head injury with all of these changes, secondary changes here, and the autolysis and brain death, which we'll talk about in just a second. Here's another 2-month-old brought to the ER unresponsive without explanation, in other words, suspicious, but this child was not imaged. This is taken from the internet, but at the autopsy, you can see there's a funny pattern here. There's not really any subdural. These veins are markedly distended, and the surface veins are distended, and there's a hemorrhage here that's medial. Now, and then here's a little hemorrhage here. Babies, another point to be aware of is that they hardly ever will get impact contusions on the surface of the brain. Hardly ever. I've seen it maybe once. And that's usually because it's a depressed skull fracture and there's a bunch of other complicating stuff going on. But you see, look at this vein. This is the vein of Trollard. It gets its own name. And it's ropey and firm and it's thrombosed, okay? So that all of this stuff is backup of blood into the dural venous sinus, and other veins will also get thrombosed. This is basically a venous infarct. Okay, so be sure to recognize this. This came in and it was a question of trauma, but it's not. This child had been vomiting the day before, which is also sometimes a red flag, but he actually had gastroenteritis, was dehydrated, and this is the consequence of that. So that's going to be one of your main differentials in these little guys. And sure enough, this has got, obvious, beautiful thrombi with a little bit of organization at the very edge, which helps. And then here in the dural sinus, you also have a little bit of these organizing clots and a little bit of iron starting to form. So, so this is a dural bridging vein and superficial cortical vein thrombosis, secondary venous hemorrhages, mural thrombi in the dural venous sinus, and so on and so forth. Okay, secondary, all kinds of stuff. Here's an acute after a craniectomy, unknown, found down, had a brain death protocol. Obviously, tons of intervention, external ventricular drain, hemicraniectomy here. I think this is where the drain went in. It sometimes can be really tough, but you really should try to see. It's nice if the whoever does the autopsy leaves the catheter intact for you in the brain. That's usually helpful, but this is a pretty extensive subdural here. And you can see, looking dorsally, this is the external hernia. I think this might have been where the drain went in right at the margin of the hernia, but you can also see that this is all ischemic. And so this, again, would be a herniation contusion in the sense that it's used, but this is because you have localized compression of these little vessels, and then you get reperfusion hemorrhage, and this is all ischemic. Now, everything's pretty much gone here because this is he went on to go through the brain death protocol, which requires examinations over 24 to 48 hours. Again, you can see the margins of the hernia here. There's reperfusion hemorrhage. Here are the lower margins of the hernia. So he had a hemicraniectomy. So this is all externally herniated with secondary changes. The other thing I want to point out to you here are some of these basal petechial hemorrhages, which are something you see in brain death. And we'll talk about that in a second as we're getting down to the wire here. I see here are some more of these. This is basically, complete tissue necrosis everywhere. And so we'll go on here. Here's another young person down, had a craniectomy, but lived for 1.5 months. And you can see that some of this has started to, where it was ischemic, to shrink down, right? Here, he even had a right temporal bone fracture as part of his acute process. And you can see that there was a contusion hematoma here, and there had been enough shift to cause a Kernahan's phenomenon on the other side, as we talked about. Also, probably a little bit of tonsillar herniation where you got a little secondary. Again, this would be kind of a resolved contusion herniation contusion. Yeah. So anyway, I'm hoping you guys are getting the gist of this. Again, you can see this at the margins of the hernia. And this is the track where the drain went through, and he may have had more than one because this looks, pretty trash, the corpus callosum here. So we're getting out of time here, but I want to also show you that the peduncles, since they got squeezed bilaterally, are actually kind of small, and you get the secondary changes here. Okay, so status post neurosurgical interventions, EVD placement with a track, and so on. So you kind of get the drift of these. Now here's one, a guy who had a assault 10 years ago, but he's now wheelchair bound with seizures. He's found dead at home. This is not the brain, of course. This is the lung. And he's got obvious big saddle pulmonary emboli here. Again, he was wheelchair bound. So here is his brain. Doesn't look like much initially, but you see he's got evidence of an old uncinate process hernia here. So, and when you look on cut section, it's subtle, but it's there, right there. So that resulted in compression of the peduncle here, right, with impingement on the descending corticospinal tract. Pyramid is totally gone here, and he's got degeneration of the contralateral corticospinal tract. So my question for you is, what's the cause and manner of death? And the answer is, I'm sure you all got it right. He had a PE, complicating hemiparesis due to old blunt force trauma of the head, but it's a homicide. Doesn't matter, that's 10 years later. That was the reason why he died. Okay. I'll quickly show you an undiagnosed tumor in a 3-year-old boy, choked on a PB&J. That's always a red flag in forensic. But the autopsy was negative except for the brain, and he had, what I'll show you, was an angiocentric glioma affecting the brainstem, which is pretty dramatic. You can see how it's bulging up above the margin of the basilar artery. The whole contours of the brainstem are completely effaced. And so obviously it's surprising this kid didn't have symptoms before, but and here's the cut face of the medulla, and it's bulging above the cut surface. there's an dorsal exophytic component here, but in fact, this was involving the entire brainstem, so it wasn't a dorsally exophytic glioma, but it was an angiocentric glioma. It even went rostrally up into the cerebellum and midbrain. So pretty dramatic case. You can see that the olives are almost effaced completely, so a diffuse glioma causing sudden death in a child. 24-year-old found dead, also had an undiagnosed brain tumor. This is the right frontal pole, left frontal pole with this exophytic tumor. And this is courtesy of Heather at the New York OCME. And you can see how it's caused this shift from right to left because there's been an acute hemorrhage into the tumor. So the guy was compensating for a period of time until he had a hemorrhage, and that was it, lights out. So these are, this is a child who had, so even a quote unquote benign tumor, if it bleeds suddenly, this is a case I had a million years ago. And when I wrote co-wrote the first tumor chapter in Escarole and Poirier, we contributed this photo, and I believe it's still in the book. All right, undiagnosed infection, pneumonia, beautiful, meningitis, and diffuse brain swelling related to inflammation and spasm of these vessels results in ischemia and swelling in the brain. So even if you didn't have that beautiful, lung with pus on it, this could be cause of death of just meningitis without a specific source. Okay, hypertensive hemorrhage. Here's a big clot originating in the basal ganglia with these jet lesions, I call them, from this arterial spurting into the parenchyma, dissecting along the white matter tracts, pushing into the ventricle, pushing the septum over. And in a subsequent section where the clot has fallen out, you see this person, if you weren't sure what was going on, say he was found down and had a scalp abrasion, and you'd say, oh, well, maybe it was trauma. Well, actually, he's got an old slit hemorrhage here in the opposite basal ganglia. So this is a vasculopath, hypertensive person, and even in the cerebellum. There's a hemorrhage in the cerebellum and an old infarct in the cerebellum. So just because you see one lesion, keep looking, you may find more. And then here is our same case of the 2-month-old with the brain death. And here you'll see what we call stasis clots, right, in the dura. So once everything stops going in and out, wherever blood is sitting, it's going to just clot, right? And so this results in brain death. This is our same case we had before with autolysis and brain death changes. I don't include that as a diagnosis because it's a post-mortem change. I may mention in the comment that, the exam may be limited by autolysis, and I don't use the term respirator brain because it has nothing to do with the respirator. It has to do with the interruption of blood flow to the brain. And this is because the cranial pressure exceeds the cerebral perfusion pressure. So nothing can get in or out. This is what my mentor, Bill Shaney, used to say. If blood can't get in or out, the clock is going to stop on reactive changes. You're not going to be able to get neutrophils in there. You're not going to be able to get macrophages in there. Only some of these capillary beds are still kind of opening and closing. They're the last ones in the brainstem. I call it the last gasp phenomenon, where you get these little petechiae here because they're the very last places to lose perfusion. And so you can see clinically, angiograms, you can see there's no real meaningful perfusion. There's nothing on radionuclide scans here, and the brain is diffusely swollen here. So just to be aware of that. And again, could give an entire talk on brain death, and we don't have time. So I'm sorry, and I know I went over, and I hope I was able to share with you a couple of nuggets that you might find useful. So I will stop here and
yes, thank you so much.
stop.
Those pictures are just spectacular. So at this time, we're going to move into Q&A. You can submit,
Okay.
we have like 5 minutes. Hopefully you have time
Okay,
for questions.
cool.
So you can submit your questions via the chat box, or you can unmute to ask a question. When submitting a question via the chat box, please make sure you're sending it to everyone so that everyone can see it. And then to unmute, select the microphone in the lower left corner. And after you've asked your question, please remute to avoid background noise. Okay, I'll give a minute to see if there's questions.
In case you're wondering, this is my late little doggy who won the blue ribbon at the pet show in May for being the cutest old dog.
Very cute.
Okay. I see. Shall I read the question, Angelica?
Yes, yeah.
Two questions.
Yes.
Can purely vasocongestive brain swelling with increased intracranial pressure causing lethal decrease be undetectable at autopsy? You mean just if you have too much blood volume? I don't want to say I don't want to say undetectable. It's very hard to know that that's the specific reason, because once you have, and I'm not sure, I can't even think of a circumstance, unless maybe you're talking about like malaria, acute cerebral malaria, where all the blood vessels are just stuffed full of red cells and, you know, that kind of thing. Then, but that also has a very typical appearance. It's kind of difficult to say, but I think you would understand the circumstances, I think, in a case like that. So let me just go back here. I don't want to miss any of these comments. Thanks, Dr. Parisi. I'm glad you were on. I miss you. Let's see, you had a second question, Carrie. Let me just try to get to it. In a purely ischemic infarct with occlusion, where does the interstitial fluid causing white matter vasogenic edema in the MCA territory come from? This is my point. It's hardly ever a purely anything, because once you damage cells, you get cytotoxic edema, but the vessels also are damaged, right? The vessels are part of the tissue that's being perfused in the brain. And whether you actually get leakage of red cells, you may only have enough compromise of the vessels in the ischemic bed to allow fluid to come out. So you will almost never have a purely cytotoxic. That's kind of my point, and why I avoid ever, you know, trying to opine about what I think it is. The radiologists, let them do it if they want. Again, the reason for them to try to distinguish is that clinically, certain treatments like mannitol, if you're trying to pull water out of the brain, you need to have interstitial edema in the brain for that to work. If you don't, it's not going to work. Steroids and so on, it won't work in certain conditions. So that's why they try to distinguish these things. That being said, a lot of times in neurosurgery, or in NICU, or NICU, neurology ICU, they will just try anything because they're trying to save the life of the person. Why else would they go to craniectomy, for God's sakes? So I think I personally don't get hung up on them. I presented them so that you can understand the concepts as they're used and discussed. But in actual fact, I don't ever even attempt to try to make a distinction among those things. So specific, Howard, let's see, what specific histological features are seen in cytotoxic edema? That's sometimes you may be able to detect swollen cells, but I don't believe you can. And if someone knows better, please pipe in. Let's see, and I'm trying to get home in on Brian's question here, but I can't seem to get it exactly in the frame. This is not letting me.
You want me to read Brian Morse?
Would you please? Because somehow it's like going up or going down. It's not letting me go to his.
He says,
comment.
you noted superior sagittal sinus thrombosis in a child due to emesis. How are these two related?
Oh, that's a great question. I'm sorry I wasn't more clear, Brian. So babies and children can get dehydrated like that, right? And so if they have gastroenteritis, I mean, that's why, I don't know if you remember during your pediatrics rotation, you would always ask the mother, when's the last time they wet their diaper? Or because if they haven't, then they're dehydrated. And once their blood volume decreases like that to the brain, you'll get venous thrombus forming. And so that's the risk factor. So I'm very glad you asked that. So they're basically hypovolemic, right? And so they'll clot off their veins, and then it's a catastrophe. And sometimes the radiologist will be able to tell, from what they call a delta sign, where when they have a cross section of the dural venous sinus, it looks like a triangle and it can be filled in because it's clotted, right? So whenever you have a dehydrated kid, it's really good to think about that. So I'm glad you asked that question, Brian.
Thanks, Rebecca.
Good. Oh, how to uncle notching. No, uncle, if you don't have brain swelling, I don't know what uncle notching means. No, in the normal brain, look at your normal brains. There's a little kind of a crease right there that's normal. I wouldn't call it, there's a little groove that's there. And in fact, in a case I had to testify in one time, they had an expert, somebody who was calling that a herniation. And I took a picture from, de-Armand Atlas, the very first picture of the base of the brain there of a normal brain. And I asked the lawyers to show that. I'm like, no, this is normal. It is not. So be very careful not to overcall that. I've seen it happen. And because if you're not looking for something and all of a sudden you might not notice that it's normal. So I'm really glad you asked that. And then someone was asking about how to cut the brain. Is this the axial section? I can tell you very quickly, you have the brain like so, right? If you're looking at it from the side, and you find the frontal pole and the occipital pole, and that's your plane. And it's not going to be flat to the table as it's sitting on. It's going to be something, skew a little bit like that. And you take your knife and you go parallel to that up to the very top. You make a slice, then you turn the entire brain over so that the very vertex is sitting on the table. And then you do coronal section, or not coronal, parallel sections through that plane. You don't take off the brainstem and cerebellum. And you just make sure when you lay them flat that you have the right on the left and the left on the right, because it's radiology convention. Try it sometime on a case that's not crucial. Mess around with it first till you get used to it. It's actually not difficult. And it gives you fabulous, I think it really demonstrates like the extent of like the midline structures, how they are pushed over. Again, we don't call that herniation, but it is. I mean, it's tissue going into a compartment it doesn't belong, right? So I hope that's helpful. I'd be glad to, maybe I should make a video or something. Yeah. Any other that I missed here? Sorry if I did. And we're a little over here. I'm sorry about that.
Yeah, I think you answered all the questions that I can see in the chat, I believe. Yeah.
Oh, good. All right. Well, you guys can find me on, I think my email is public domain. Or through AANP, just ask them. Oh, Howard, thank you. Yeah, I'm so glad to know you guys were there. Cheryl, thanks. So glad so many pals were on. It's really wonderful to be able to. Thanks, Murat.
We are at time.
Yeah.
Thank you again for joining today's AANP Teaching Rounds presentation. We would ask that you take a few minutes to complete a short evaluation. Completion helps ensure accurate reporting to the accreditation board. A link to the evaluation will appear on your PathLMS screen upon the conclusion of the Zoom meeting, or you can navigate back to the main course and select the evaluation option. Once you have completed the evaluation and selected your credit amount, please then select the appropriate certificate based on your credentials. The PowerPoint slides and recording will be posted to the AANP website within the next week. Thank you again to Dr. Folkerth for an excellent presentation. This concludes the session for today.
Thanks, everyone. Take good care.